All right, so we have a few things to talk about today. Adrenal gland, pancreas, gonads, some relatively insignificant primary endocrine glands and secondary endocrine organs, okay? We should have some time at the end of the class to maybe pull out microscopes and look at a few slides, okay? That's going to be it. So let's start with the adrenal gland. So adrenal means above the kidney. Adrenal gland has two distinct regions, the outer cortex and inner medulla. Now, adrenal medullary hormones, you know them. Those are epinephrine, norepinephrine. We covered them when we talked about sympathetic system. So far, going along. So those are water-soluble medullary hormones. And we're not gonna talk about this, okay? One little bit that I wanted to share, not for the exam, don't worry, I just listened to the podcast this morning. You know how when people get stressed, they get gray hair? There is a publication in Nature in a mouse model. It demonstrated that it turns out our cells, melanocytes in the hair follicles, have adrenergic receptors. And when we get stressed, we produce norepinephrine. Norepinephrine acts on those adrenergic receptors and basically stops those cells from dividing, and we get gray hair. It's really cool. So sympathetic response gives us gray hair. So we're not going to talk about norepinephrine, epinephrine, the hormones of acute stress. We're going to talk about cortical hormones. Okay? We good so far? So cortex produces lipid-soluble hormones. As a reminder, there are three layers. Zona glomerulosa, zona fasciculata, and zona reticularis. And now, zona glomerulosa produces mineralocorticoids. Zona fasciculata produces glucocorticoids. Zona reticularis produces androgens. We're going to briefly discuss all those hormones. We're good so far? And I'm going from superficial cortex to deep cortex, right? From out in. So far, everybody is keeping up? Okay. So we're going to start with mineralocorticoids. And the key mineralocorticoid hormone, question? Okay, it's okay, that's fine. Is aldosterone. Now you may wonder why I didn't put any stimuli, what stimulates the production of aldosterone. We're going to figure it out. I'm going to tell you what it does, and then we're going to figure out what stimulates aldosterone. So aldosterone increases sodium reabsorption in kidneys. To make it clear, reabsorption means that sodium here, it goes from urine back into the blood. Does it make sense? Okay. So, elevated sodium in the blood. Now, you have heard before, I'm pretty sure, about the process called osmosis, right? Osmosis is the movement of water towards solutes. Now, here's the thing. When sodium goes in the blood, water follows sodium. Does that make sense? sodium draws water with it. It's basically one of the fundamental mechanisms that we will come across many times while we're studying AP2. Okay? So water follows sodium, which means increased water retention. Does that make sense? Now I have a question for you. When water is being retained, is being moved from urine into the blood, when water goes into the blood, what happens to the blood volume? Say it out loud, I cannot see. Is it going up or down? When water goes into the blood, blood volume goes up. When blood volume increases, how does it affect blood pressure? Imagine you have a pipe system, and now you need to pipe way more water through that system. So blood pressure will go up. Does that make sense? We good? Let's identify the main effects, and then we will identify the stimuli for aldosterone. Is that an effect, elevated sodium in the blood? It sure is. Water retention, is that an effect? Elevated blood pressure, is that an effect? So remember, it is negative feedback unless mentioned otherwise. Okay, you got it? Negative. So, if one of the effects is elevated sodium in the blood, what would be a stimulus for aldosterone production? If the effect is sodium going up, then the stimulus is sodium down. If the effect increased water retention, then the stimulus is water loss or dehydration. If the effect is elevated blood pressure, then the stimulus is low blood pressure. Does that make sense? Are we clear? Blink once, yes. Twice, no. Okay, just no. Okay, so a couple more effects that are not really linked to this. Aldosterone responds to elevated potassium. Okay, and the effect of aldosterone is increased potassium excretion. Does that make sense to you? So, for instance, if you eat something potassium rich, like bananas or potatoes, okay, aldosterone will go up, which will lead to the excretion of potassium, not by much. And it's usually very transient, but just we'll have to know. So far, we're all right. Now, I want to emphasize one feature here about the effects of blood pressure. So blood pressure effects, they are not a direct effect. Basically, what I'm saying is, if your blood pressure goes down, your adrenal glands do not feel it. Let me show you how it works. Blood pressure goes down, your kidneys produce hormone called renin. Elevated renin leads to increased production of angiotensin. That's the liver. And angiotensin stimulates aldosterone. Is that clear? Okay. Now, as I mentioned, any questions about this whole scheme? Good? I'm going to leave it. I'm going to say a few words. So first of all, remember that all hormones of adrenal cortex, all of them are steroid hormones. So they are all fat soluble. So the receptors for aldosterone, for instance, are inside of the cell. Is that clear? Now let me ask you this. Look at the skin closely. Remember that each hormone has to interact with the receptor, right? I'm giving you a hypothetical situation. I have a drug that inhibits aldosterone receptor. I'm going to say it one more time. So we have aldosterone, right? Aldosterone has to interact with the receptor in order to act. I have a drug that inhibits this process. So aldosterone cannot bind to its receptor anymore. Question: if I use this drug, what effect is it going to have on your urination? You can look at the skin. If I use the inhibitor of aldosterone receptor, what effect is it going to have on your urination? Exactly. It's a diuretic. Very good. Because when you inhibit the receptor, water is not retained and it stays in the urine and you produce more urine. Does that make sense? This aldosterone receptor inhibitor, what effect is it going to have on your blood pressure? Exactly. It's going to go down, and aldosterone receptor inhibitors are antihypertensive drugs. That makes sense? See, you're getting the gist of this whole regulation thing. Like, we increase this, what's going to happen? We decrease that, what's going to happen? Make sense? Good? Okay, now, I want you to kind of keep in mind on the back burner of your mind that elevated aldosterone levels ultimately leads to elevated blood pressure. Okay? Just remember that. Because it will come in handy when we're going to talk about our next one, which is going to be cortisol. So, cortisol is a hormone of a chronic stress. So, stress. Now, let me ask you this. Stress, is that a psychological effect? Yes. So, anyone here is claustrophobic? Okay. Anyone here afraid of heights? Yeah. So, I want to go to, what's that park in Sandusky? Yeah, Cedar Point. I want to go Cedar Point? No, I don't want to. Anyone else wants to go to Cedar Point? No, seriously. Like, do you like Cedar Point? Yeah, sure. Yeah, it's fun for you. So you enjoy it. I would shit my pants right there. Like, for me, it's unimaginable stress. I'm stressed just like by looking at it. Stress is psychological. What is stressful for you may not be stressful for me, and the other way around, right? So stress is largely individual. So it's processed by your limbic system, by your cortex, and eventually the stress signal reaches your hypothalamus, which in response to stress signal produces CRH, corticotropin releasing hormone. CRH acts on the anterior pituitary gland, which produces a hormone that we can call ACTH or corticotropin. So ACTH stands for adrenocorticotropic hormone, which is a synonym to corticotropin. And corticotropin name means into the cortex, right? Tropin means the location. Good so far? So ACTH or corticotropin acts on the adrenal cortex. We call it AC. And as the result of it, adrenal cortex produces cortisol or hydrocortisone, okay. So far, you follow in a loop, right? Now, cortisol, and I'm going to be hugely politically incorrect. Cortisol is not opioids, it's not cocaine, it's not alcohol, it's not going to relieve the stress, just you don't care anymore. It will provide you with the resources for general adaptation to stress, mostly energy. So what is the first molecule that you think about, except ATP? What's the first source, sort of what's the first nutrient you think about when you think about energy? Huh? Good for you, but unfortunately no. Carbs, right? First you think about glucose. First is the glucose. So effects of cortisol is going to be elevated blood glucose. Okay? And second remark was lipid. Okay? So cortisol will stimulate lipolysis, breakdown of lipids. Does that make sense? By any chance, anyone remembers what lipolysis produces? What are two types of, what are two molecules that comprise triglycerides? One is glycerol, and another is free fatty acids. Yes, free fatty acids. So it's kind of, just to remember, you're going to have elevation of blood free fatty acids. Okay? Now imagine that you are under constant stress. Your work conditions due to the pandemic changed, and now you don't know if you're going to have a shift tomorrow or day after tomorrow, what time. So constantly stressed, and your kids are at home and you have no idea what's going on there, how they school. So you are under constant stress, right? Technically, using this hypothalamus, pituitary, adrenal axis, HPA axis, technically here, you can expect that your blood glucose will be skyrocketing. You're going to lose all fat and everything, right? Because this is not a means to put a negative feedback on the stress. But you have to include negative feedback. It has to be some inhibition. So what has inhibitory effects? Cortisol, right? So cortisol itself inhibits its own production, just to keep it in check. Does that make sense? It's a classic hormonal axis. So far, so good? You following me? Getting along? Now, before we move on to overall effects of cortisol, does this regulation make sense? If I ask you, if I will somehow increase cortisol, if I will inject cortisol, what's going to happen to the levels of CRH and ACTH? In the endocrine system, it's always increase or decrease. So if I inject cortisol, what happens to levels of these two hormones? If I inject cortisol, what happens to the levels of these two? B, yes. Just, I'm just checking with you. Okay? Now, let's take a look at body effects. Lipolysis, breakdown of fats. What's going to happen to your body? You're going to lose weight. You're going to lose fat. No, seriously. I can tell you, I had a period of my life, several months of extreme stress. I did not work out, nothing. I was eating crap, and I was losing weight. Okay? It has a really profound effect. However, there is a culprit here. See blood glucose? Constantly elevated blood glucose will give you what? Bingo. Seriously, it will. So, elevated levels of cortisol will lead to diabetes, will lead to disruption of proper metabolism, and in the long run, you may end up with obesity because of the disruption of proper metabolism due to the elevated blood glucose, insulin resistance will get there, and because of simply compensatory effect of eating. I love to eat away my stress. I don't know about you, okay? Because it is a very well known phenomenon. People just eat because it makes them feel better. Does that make sense? Now, I'm going to introduce some terms. There's certain terminology regarding metabolism that I want you to be aware of. This terminology is this. So, blood glucose. Where can you get glucose into the blood? What are the sources of glucose? Can you make glucose from scratch in your body? Yes. This process is called gluconeogenesis. Okay? Gluco for glucose, neo for new, genesis for making. So in case of cortisol, cortisol stimulates gluconeogenesis. Does that make sense? Are we clear? Another way to get some glucose is if you take glycogen and break it down. Glycogen that is stored in your muscles and liver. So that will be a process called glycogenolysis. Am I clear? Glycogen lysis. Does that make sense? And of course, lipolysis. So this basically summarizes the effects of cortisol on the human metabolism. Am I clear? And this is, when I say you must know this terminology, let me explain what I mean. When, not if, but when, on the exam, you will see these words, you must know what they mean. Sarah and TV will tell you, you can ask me questions during the exam. I will try to clarify, but I want to be very explicit. If you come and ask, what is gluconeogenesis? I will not clarify. You must know that. Does that make sense? So this is the term that you must know. There are going to be a few more. We'll figure them out today. You good? Any questions so far? So what are other effects of cortisol? Most profound effect is anti-inflammatory. Basically, immunosuppression. Okay? You didn't have a chance to observe my marvelously swollen foot after I was stung by a hornet. But it happened on Sunday, right before classes started, and on Monday I went to urgent care, and guess what I got? I got prednisone. And it went back to normal in basically a day. So, hydrocortisone, cortisol, prednisone, dexamethasone, all those steroids, they have very profound immune inhibitory effect. The flip side of it, you have to be, when you take those drugs, you have to be very careful about possible infections because they weaken your immune system overall. That make sense? Questions about this particular one?
So when you're working out, is that the same effect?
Brief answer, yes. You are producing cortisol, and it is mildly immunosuppressive, but you also vastly stimulate your innate immune system, which is well documented. So it's kind of a balance between immunosuppressive effects of cortisol that you produce when you're working out and immunostimulatory effects of reactive oxygen species, stimulation of innate cells, and so on and so forth. I can tell you this. If there was a study, I have it somewhere at home, like in my kind of papers. There was a study showing that if you will try to plot the effects of workout, effects of physical activity on the immune system, it looks like this. So that's the baseline. And this, extreme athletics. Like if I will try to run 100 miles a week, okay, that is for an average fall. If you progressively train for it, that may be a different story. But if you overtrain, yes, you're going to get massively immunosuppressed because of accumulation of cortisol. You are absolutely right. Did I answer your question? Okay. Now, I want to give something here. Remember we talked about aldosterone, how it increases blood pressure? Well, aldosterone is produced in zona glomerulosa, while cortisol, which is glucocorticoid, because it regulates glucose metabolism, produced in zona fasciculata. But when ACTH acts on the adrenal cortex, it mostly stimulates cortisol. But as a bystander effect, it leads to increased aldosterone production. And how aldosterone will change your blood pressure? Aldosterone, what is it going to do to your blood pressure? Yep. Basically, that's the mechanism of elevated blood pressure under the constant stress. Stimulation of adrenal cortex will lead to slightly elevated. You're not going to have 200 over 120, but you well may be 140 over 100, which is lower border hypertension, right? And that will eventually become chronic. Does that make sense? So that bystander stimulation of zona glomerulosa will lead to elevated blood pressure. Good? Now, abnormalities. Too much. Cushing's disease. So symptoms, diabetes often, obesity or overweight, specifically a buffalo hump and a moon face, swollen face, or obese face. Cushing's may come from some kind of adrenal tumor or from overusing prednisone as anti-inflammatory, cortisol as anti-inflammatory. okay, because it leads to such a massive elevation of blood glucose that it starts to deposit itself as a fat. Okay? So little is Addison's. That's I call it John JFK disease. John Fitzgerald Kennedy had Addison's disease. You are fatigued, your energy is low. Since cortisol plays a role in skin coloration indirectly, usually skin darkens. JFK lived on steroids. Does that make sense? Good? So just like with TSH, TH, thyroid, basically if you have someone, another example, if you have someone with Cushing's, so low cortisol levels, what do you expect CRH and ACTH will be? Huh? Yeah, they're going to be high. So you can test like all three and see the person has Cushing's. Well, like Addison's or Cushing's, right? In Addison's, cortisol is low. These two are high. In Cushing's, cortisol is high. These two are low. Follow along? Any questions? Let's talk about zona reticularis, which is not really super important in most cases. It produces androgens, so sex hormones, but quite frankly, it's not the main source of sex hormones for humans. Gonads are, right? So your testes or your ovaries are the major source of sex hormones. It still can produce, for instance, in postmenopausal women, zona reticularis becomes one of the main sources for estrogen. But there is one very interesting condition that's associated with this particular set of hormones, cortical hormones. It is called androgenital or adrenogenital syndrome. So we're going to start with a condition which is going to be is very, very low or complete absence of glucocorticoids. Namely, let's say cortisol. So your adrenal gland does not produce cortisol. I'm trying to train you to kind of imagine the axis in your head. So if there are no glucocorticoids, how is it going to affect levels of CRH and ACTH? They're going to be up or down. No cortisol at the bottom of the axis. They're going to be up, right? CRH and what's important, ACTH will be elevated. Now remember that ACTH stimulates adrenal cortex, and it kind of stimulates all of it. Does that make sense? All layers of the cortex. So it will stimulate, overstimulate, overstimulation of zona reticularis. Now, zona reticularis produces androgens. So, overproduction of sex hormones. But here's the trick. Look, which organ normally produces sex hormones? We didn't talk about it. Anyone knows? No? which organ or organs normally produce sex hormones? They pair. So it's testes in males and ovaries in females. Testes produce testosterone, basically, and ovaries produce estrogen, right? What happens here, overproduction of sex hormones, if it's a male, some extra testosterone isn't going to make matters worse. What's going to make matters worse is that you're going to have a shitload of estrogen coming out of the cortex. Does that make sense? And in females, it's not estrogen that's going to be a problem. It's going to be uncontrolled testosterone that gets out of the cortex. That will be an issue. So what essentially happens? Excessive testosterone in females leads to masculinization. Mostly hair growth. And the body composition becomes more male-like. Does that make sense to you? Okay. In males, this mostly happens during the intrauterine development and leads to so-called the first is hypospadias. Hyposperia is basically an ambiguous genital. So a newborn boy with a hypospedia will have a smaller penis, and under the penis there will be vestigial vagina. I mean, not fully functional vagina. Does that make sense? Like feminization of a male. Understood? Good? Very simple question. Look at this and tell me how you treat it. What do you give to a patient? It is really like that. We even name this group of drugs. What do you need to give a patient to kind of stop it all from happening? So it's written on the whiteboard what you need to do. What is the underlying cause of this problem?
ACGH.
What is the underlying cause? Say. Give them glucocorticoids. That's it. Just give them like prednisone or whatever, cortisol, and that's it. It's going to be a lifetime treatment. It's not going to end ever, but that's treatment. That make sense? We're good? Any questions on the cortex? Okay, let's get to my favorite. Pancreas. Okay. In the pancreas, the endocrine structures are Langerhans islet. We're going to be interested in specifically three types of cells. Quite frankly, well, who am I kidding? Two types of cells. I'm going to mention three, but one is not an example. So we have alpha cells, beta cells, delta cells. I'm going to be focusing on alpha and beta. There's a fourth type, which is B cells. Not talking about that. Alpha cells, which is glucagon. Beta cells produce insulin. And delta cells produce somatostatin, which you may remember from the name growth hormone inhibiting hormone. That's the cell. We're good so far. Okay, now let's outline the basic concept of regulation. So here you have glucose. If the glucose levels are high, what's produced? In response to high glucose levels, which hormone is produced? Insulin. And what does it do to glucose levels? They go down. If glucose levels are low, which hormone is produced? Glucagon. And glucose levels go up. This is the regulation of glucose in the nutshell. We're going to talk way more about it, right? Okay, so first of all, we need to figure out how your pancreas knows when to produce insulin. That's your beta cell. We're going to focus mostly on insulin. That's your beta cell, right? I'm not going to draw a nucleus, it's somewhere there. And one more question. Glucose, is it hydrophilic molecule or hydrophobic? That's a sugar, yeah, it's hydrophilic. So hydrophilic molecule, can it cross the membrane directly? No. So there are specific transporters called GLUT, which is glucose transporter. There are different types like GLUT1, GLUT2, GLUT3, GLUT4, nobody cares. So there's a transporter, and when glucose levels outside of the cell increase, glucose diffuses into the beta cell. Does that make sense to you? Okay. Glucose diffuses in. Generally speaking, what do cells use glucose for? In the form of eventual mitochondria. Yes, you're absolutely right. How do we call this whole process with mitochondria and shit? Cell respiration. But what's the main outcome, energy-wise? Bingo, ATP. More glucose, more ATP. Make sense? Now, in this case, we briefly mentioned it when we talked about mechanisms of taste sensation in humans, NAP1. But ATP can be a ligand for ion channels. And in this case, ATP serves as a ligand which closes potassium channels. Okay? Now, normally, these potassium channels would let potassium out due to the differences in concentrations, but intracellular potassium is higher. Okay? When they are closed and potassium cannot normally leave the cell, and positively charged potassium starts to accumulate inside of the cell. Accumulation of positively charged ion in the cell. How does it change membrane potential? Makes it more one. Collective effort, nervous system. Accumulation of positively charged ion inside the cell makes the membrane potential more pure, positive. And more positive is a D-word, which is a noun, some kind of polarization, depolarization. So beta cell becomes more positive, and becomes depolarized. Does that make sense? Depolarization opens calcium channels, and due to the concentration differences, calcium flows into the cells. Well, in fairness, every instructor here says that AP1 is the foundation for AP2. I'm just getting you. I'm just showing you what. Remember synaptic transmission? When calcium gets into the presynaptic neuron, it leads to the release of vesicles, right? So calcium here causes the release of insulin from the vesicles. That makes sense? So once again, glucose diffuses into the beta cell. That leads to the increased ATP production. That closes potassium channels. That causes depolarization. Depolarization opens calcium channels. Calcium leads to the insulin release. Right.
So that's the main purpose of beta blockers, to stop insulin?
Now, so beta blockers, you probably make sense. So beta blockers, they, from a different sort of thing, they block beta adrenergic receptors on the heart, reducing the, I don't remember if it's a heart rate or contractility. Can't tell from top of my head. One of these two. So it inhibits the cardiac activity and reduces the blood pressure. Does that make sense? Believe me, you don't want to mess with beta cells, because it's so precious, as we will discuss in a minute. Okay? So far, does that schematic make sense? Now, let's take a look. We're going to specifically look at the effects of insulin on the blood glucose. I'm going to ask you a stupid question, open question. Why do we need to reduce blood glucose? What's the problem? What's the problem with blood glucose being 800? No. Forget about it. By itself, why do we need to reduce blood glucose?
Is there such a thing as overproduction of ATP?
No. Huh? You're getting there, but it's actually quite opposite. Well, the answer to this question, if I ask it in that particular form, why do we need to reduce blood glucose? The answer is, we don't. Blood glucose by itself isn't a problem. We have to think not why we need to decrease, but what is the goal of insulin? Because if you think about it, okay, it reduces blood glucose, but how? What happens? Where does it go? It doesn't, disappears. It doesn't disappear in the thin air, right? Something has to happen to it. And you have to think, okay, what's the goal of glucose? Why glucose? It's the energy source for the cells. Does that make sense? So when we eat something, it's being digested. Let's say we eat, I'm going to bring this up. We eat a cake in the Temple of Diabetes, which, if you don't know, it's in Lyndhurst. It's called Cheesecake Factory. Okay, we eat a cake there, and we have a massive load of glucose in the bloodstream, right? Glucose in the blood is useless. It has to get to the cells. Does that make sense? Now let's draw a blood vessel. Okay, those are endothelial cells. Okay? And that's your glucose here. Glucose in the blood, as I mentioned, is useless. It has to be delivered where? In the tissue. Does that make sense? Because these are the cells that need glucose. Are you following me? So what insulin does, it opens this little glucose transporters. So glucose can get from blood into the tissue. Does that make sense now? So insulin is a chemical signal that we're going to put down the effects of insulin here. Insulin is a signal that increases glucose uptake from the blood into the tissues. Am I clear? Good? Once glucose is in the tissues, what is it going to be used for? ATP synthesis. In the process of cellular respiration, I just use the term, so first step of cellular respiration is glycolysis. So we can say that insulin massively increases glycolysis, breakdown of glucose, right? Now, what if you synthesized all ATP that you can? Can you store glucose? Yeah, sure. Liver and muscles can store it in the form of glycogen. So insulin will increase glycogen synthesis or glycogenesis. Does that make sense? All those terms you need to know. So increased glucose uptake, increased glycolysis, increased glycogenesis. Now, remember, you are in the temple of diabetes. So this slice of cake is absolutely massive. You stored all glycogen that you could, but glucose keeps coming. Can you store more of it in some other form? What form? People will all be in quarantine. I stepped on the scales recently. Lipogenesis. I usually compare it to this. Look, glucose is groceries. First, you need to take glucose. You need to take groceries from the store to your house, right? That's a glucose uptake. You can use those groceries to cook immediately some food. That's right away ATP synthesis. You can put some stuff in the fridge. You will use it in like a week or so, glycogenesis. Or you can throw perishable items or perishable items in the freezer, non-perishable items in the pantry. You see? That's lipogenesis. That's super long-term storage. Does that make sense to you? Good? Clear? Awesome. Now, seriously, no trick, simple question. When do you produce insulin? After what? After you, do what? Yes, after you eat. Make sense? So, not only elevated glucose will be stimulus for insulin, but also elevated amino acids, because that's the product of protein digestion, and elevated free fatty acids. Okay, that makes sense? We're good so far? And that actually shows one more thing. When bodybuilders, and all of them take steroids, I have a buddy, my former student, who used to be a professional bodybuilder. I asked him about that every day. If they tell you they don't, they lie. They still take it, but they also take insulin because insulin helps them to take more amino acids from the food. Does that make sense? It's really a complicated endocrine kind of regimen. So, okay. Now, sort of on the side note, insulin is a protein, well, peptide protein, whatever you want to call it, and the receptor obviously is on the cell surface, and it's one of the few tyrosine kinase receptors. So you've got cell surface, you've got a receptor, and you've got a tyrosine kinase in the cytoplasm, and it phosphorylates all kinds of proteins, and they just do all this wonderful stuff. So far, are you following? Okay, diabetes. We'll get why I called Cheesecake Factory temple diabetes. Diabetes. One is so type 1. No beta cells. If there are no beta cells, what does that mean in terms of insulin levels? Can you produce insulin? So no insulin. This is a genetic / autoimmune disease, usually manifests early in life. Okay? You can't do anything about it, either there or not, right? And then there's type 2. In type 2, it's a lifestyle disease. So let's say every day you eat a slice of cake at the Cheesecake Factory. Don't get me wrong, they're delicious. So glucose is massively elevated. Massively elevated glucose, what does that mean in terms of the insulin levels? Massively elevated. And then you have a story of a boy cried wolf. When insulin is constantly up, the signal from the insulin on the cells of the muscle tissue or liver becomes kind of muted. You know what I'm talking about? Like with people who are addicted to opioids. The same dose doesn't make them high anymore, so they have to increase the dose because their receptors become resistant. Constantly elevated insulin leads to what we call insulin resistance. What it means, in order to, look at this, in order to open these things up on endothelium, you have to have more and more insulin all the time, which creates a positive feedback loop, a vicious cycle. You need to add insulin, which promotes insulin resistance, which requires even more insulin to control that condition. Does that make sense? Luckily, this condition can be fairly easily intervened by lifestyle changes. It's well known that caloric restriction works. It reduces insulin resistance. Exercise, and interestingly enough, low intensity long term rather than high intensity short term works better. So basically, walking for like regularly is better than lifting one time a week. And I want to be very clear. When I say it's a lifestyle disease, it doesn't mean that I cannot get it. There is a genetic component to it. But as Dr. Nussbaum likes to say, there is a way that no one gets type 2 diabetes. You eat lean chicken and crunchy vegetables, and before you have a meal, you walk 3 miles. You know, like, that's absolutely extreme. But yeah, in this case, you're not going to get diabetes, But in general, I know folks that, have type 2, their body weight is controlled, they exercise, but that's unfortunate. Genetic predisposition to that. That make sense? I'm trying to think what I forgot to say. Yeah, it's very heavily associated with obesity. If you look at the map of diabetes, it correlates with obesity perfectly. And it's probably the most common, not probably, it's the most common endocrine disorder in the United States. Diabetes, especially type 2. Okay, so far we're good. I'm feverishly trying to think if I forgot something. Oh yeah, I wanted to mention a really interesting graph, which is the glucose tolerance test. So you can, again, I'm not suggesting you're doing it, but it can be done at home. So you need to drink a bunch of sweet water, ideally the glucose. I have these calculations somewhere, how many grams per kilogram, whatever. So drink a bolus of glucose, and then you start measuring your blood glucose using the strips. And if you're not diabetic, and that's 2 hours. That's what it's going to look like. So in 2 hours, it's going to go back to normal, right? And this is going to be less than 100. And if you're diabetic, this is what's going to look like. Doesn't go back to normal, and this is more than 125 milligrams per deciliter. That makes sense? I'm not going to ask these clinical parameters, just wanted to share it. I want to do something for myself. Okay. I did it on myself. So just measure 15, 20 minutes. Okay. Let's talk about glycogen, and then to kind of conclude this, I'm going to tell you why Cheesecake Factory is a template factory. Not the glycogen, glucagon. So, glucagon. Your blood glucose is low, so now what do you need to do? You need to somehow get the glucose out of the tissue into the bloodstream. Does that make sense? Good? How do you do it? What should happen to your glucose uptake? Tell me. Now you're trying to get glucose into the blood. So glucose uptake has to, it's all up and down, go down. Now, instead of using glucose, you have to start making it from scratch, am I right? How do we call it? Gluconeogenesis. Make sense? Instead of making glycogen, you have to open your fridge and start getting the food out. Does that make sense? It's going to be glycogenolysis. Instead of putting stuff in the freezer, you have to start, thaw it and cook it. So not lipogenesis, but lipolysis. Are we clear?
So you said this is for the one where the blood doesn't have enough glucose.
Yes. So this is the situation, want the analogy with the quarantine. Situation when you test positive, you can't go to store. And now you have to figure out how you're going to feed yourself without going to the grocery store. So your grocery store, trips, are done. There's no uptake. You're not bringing anything from the grocery store. Uptake is low. So you have to start making your own food. I don't know, growing potatoes in the backyard. You have some stuff in the fridge. You break down glycogen to get glucose in the bloodstream. And you have some stuff in the freezer in the pantry. So you break your fat, which you eventually can kind of plug into the glucose synthesis part. Does that make sense? Now, really simple question. If glucagon has these elevated effects on gluconeogenesis, lipogenesis, lipolysis, what effects does glucagon have on these three? It's all about increase. Yes, it will decrease all these three processes. Does that make sense? And insulin will decrease these three. In terms of the effects, insulin and glucagon are mutually opposite. Whatever insulin increases, glucagon decreases. Am I clear? Am I clear? Fantastic. Before we get a break, have you been to Cheesecake Factory? I can pause it. I'm not going to say anything profoundly important. We have gonadal hormones to talk about just a little bit. Most of the gonadal hormones talk will be when we get to reproductive. So I will kind of limit stuff here. Pineal gland, thymus, kind of brief mentions, and then secondary endocrine organs. Also, secondary endocrine are going to be very brief because we're going to cover this stuff when we get to the specific organs. So gonadal. Okay, let's lay it out. I'm not going to put stimulus yet because it's more of a cyclic thing. So we're going to start with the hypothalamus, which produces gonadotropin releasing hormone. So gonadotropin releasing hormone acts on the anterior pituitary gland here. It produces gonadotropins. There are two of those. There's luteinizing hormone and follicle stimulating hormone. Now, why do we call them gonadotropins? Yeah, I'm impressed. Because they go to gonads. They act on gonads. Now we're going to talk about the regulation of gonadal axis, and this is called hypothalamus pituitary gonadal axis. We're going to talk about the regulation in males, not in females. I will explain why right now. Because the regulation of these hormones in males is much simpler. Regulation in females is more complex and more elegant, but we're not going to do it now. We're going to save it for reproductive, and then we're going to go into detail. Okay? Deal? So, in males, the gonads are obviously testes, right? So follicle stimulating hormone acts on testes, and the effect, look, follicle stimulating, it stimulates some kind of a follicle. Essentially, follicle stimulating hormone is responsible for spermatogenesis. So in response to FSH, cells produce sperm. But luteinizing hormone is also essential because it acts on testes as well, just different cells, okay, different cells. And in response to luteinizing hormone, testes produce testosterone, which is necessary for sperm maturation. I'm going to make a terrible joke, but don't think that's like right testicle. produces testosterone, left testicle produces sperm. No, just Leydig cells produce testosterone, and sustentacytes, Sertoli cells, regulate the sperm maturation. Okay, so only testes. Good so far? In addition to testosterone, testes produce a hormone, inhibin, which can inhibit activity of hypothalamus and anterior pituitary gland. Okay? And testosterone itself can do the same. Are we clear? Does that make sense? Can you see that? So, I'm going to plug in a couple more things here. So, first of all, sperm, I'm going to put inhibin. The amount of inhibin produced depends on the amount of sperm. So now let's take a look at the regulations. GnRH stimulates gonadotropins. Gonadotropins stimulate testosterone. Testosterone immediately inhibits production of these hormones back. Am I clear? So testosterone basically keeps these hormones in check. When I say inhibit, don't take the word inhibition as it shuts them down. No, it's our favorite teeter-totter, okay? It keeps the system at the proper level, like proper baseline. In the meantime, sperm keeps being produced. Make sense? Sperm cells accumulate. As they accumulate, inhibin levels go up. Can you see that? More sperm, more inhibin. You with me? More inhibin, more inhibition. More inhibition, less gonadotropin releasing hormone, less gonadotropins, less sperm generation. Does that make sense? So basically, initially, sperm is accumulated at the pretty high levels, and then as it gets accumulated, the rate of spermatogenesis goes down. Make sense? Then, if ejaculation occurs, amount of sperm goes down, levels of inhibin go down, inhibition goes down, that system that axis gets activated. Am I clear? Sperm accumulates, it gets inhibited. Ejaculation gets activated. This is why there is not really any specific stimulus. You see? It's sort of a system in itself, self-contained. It does not require any external stimulus. Is that clear? We're good? One plug for performance enhancement drugs. So imagine that an athlete uses injectable testosterone as a performance enhancement drug. So testosterone is massively increased. What effect is it going to have on gonadotropins? Up and down. If testosterone goes up, gonadotropins go down, yeah. Now gonadotropins stimulate testes. Without gonadotropin stimulation, testes will shrink. Like physically shrink. And if the person takes testosterone for an extended period of time and decides, I'm going to stop using it, then this person will be sterile, will be infertile, because testes just basically the structures of that. That make sense? This is why, quite frankly, nobody uses testosterone. There are synthetic analogs that are safer. I'm not saying you should use them, God forbid, no. But they're safer, they are metabolized differently in the liver, they're not going to be converted into estrogen, they're not going to affect HPG axis as much, so you're kind of better shape. Questions? Good? Okay. Couple of very brief hormonal stories. thymus, responsible for T cell maturation, so basically immune system. Right about here. There are three hormones: thymosin, thymolin, and thymopoietin. That's it, like seriously. Its activity goes down with age. In us, thymus is pretty much fibrosed and gone. Not super interesting endocrine. Right? Pineal gland. So it is located in the epithalamus, responsible for production of melatonin. So how it works? Light melatonin goes down. Dark melatonin goes down. What I want to say about this particular scheme. First of all, how we perceive light, we perceive it with our eyes, right? So right now, your retina sends the signal to the visual cortex and to the thalamus that, hey, it's light here, this signal is relayed to hypothalamus, hypothalamus relays it to pineal gland does not produce melatonin. It's dark, produces melatonin. Now, bad news for all of us, in us, pineal gland is practically gone. We do not produce that much of the melatonin. In kids, it's very active, in adults, not as much. You can often read, melatonin regulates your circadian rhythm, like sleeping patterns. First and foremost, your sleeping patterns are regulated by hypothalamus. So if I will leave you in this room for several days with the lights on, blinds shut, door closed, you will still be falling asleep, more or less following your normal pattern. You'll be somewhat screwed up, okay, but you will get sleep, I don't know, like midnight, and you woke up at 6, 7 a.m. So you will get circadian rhythms are more than just melatonin. Melatonin is one of the few wonder drugs that you can buy at a pharmacy in that snake oil section where they sell things like collagen, coenzyme Q, whatever, which are quite frankly useless. Melatonin is not if you are jet lagged. It helps to reestablish the sleeping pattern. Okay, it is not a sleep medicine. If somebody has a legitimate sleep disorder, it's not going to help. It can help to reestablish, like if you were studying like crazy hours and stuff like that. Yeah, but it is not a fundamental drug against the sleep disorder. Got it? Another thing, by the way, I think it's called 5-HT. Basically, it's a serotonin. You can buy serotonin in that same section. Serotonin is the precursor to melatonin. So serotonin will be converted. Good? Any questions on that stuff? Okay. Let's talk about secondary endocrine organs. And not going to spend too much time. I'm going to start at the heart and go down. So we're going to start with the heart. So heart produces atrial natriuretic peptide. Natriuretic. What's this symbol? Which element does it designate? Sodium, yes. But in many languages and in Latin, sodium is actually natrium. Okay? So this is why Na. So natriuretic peptide means that this ANA increases secretion of sodium. When I say secretion, it means in the urine, right? So increased release of sodium in the urine. Let me ask you this. When sodium gets into the urine, what follows sodium? It should be reflexed by now. Yes. Increased water secretion. Do you start pee more or less? More or less? More. You pee in more. When you pee more, how does it affect blood volume? You get rid of water, your blood volume decreases, yes. And how does it affect blood pressure? Lower, yes. What's the stimulus for production of this hormone? Huh? If it makes your blood pressure go down, the stimulus is high blood pressure. Look, it's not an insult. Speak louder. I have a louder voice, but you get muffled in the masks. It's really hard to hear you. Does it remind you something that we talked about today? Which hormone? Anyone remembers? Also starts with A. Huh? Bingo. A&P is opposite to aldosterone. Make sense? Like literally opposite to aldosterone. We good with this? I'm not going to talk about the lungs. There's not much hormonal production or conversion. So we're going to switch to stomach. Stomach produces few hormones. I'm going to mention ghrelin. It's produced when your stomach is empty. What do you think? What kind of feeling do you think it stimulates? You don't have to raise your hand, just yell. Hunger, yes, it's a hormone of hunger. I usually say, tongue in cheek, that it's one of two hormones which affects organ overcome, right? If you're hungry, you can not eat or something, okay? I'm going to put these two, gastrin and histamine. So, in fact, histamine, yes, that same histamine that gives you allergic reaction, yes. Histamine stimulates gastrin, and gastrin stimulates stomach digestion. We're going to talk a lot about effects of gastrin on digestive system when we get to the digestive system. So far, so good? Okay. Now, your stomach produces serotonin. Your stomach produces somatostatin. It's all going to be later, not really important. I'm highlighting some hormones that I think are most crucial, okay? Together with the stomach, let's get down alimentary tract, talk about gut, okay? So one set of hormones is, I'm going to put them together, secretin and cholecystokinin, okay? So these two are produced when food ends up in your intestine. Does that make sense? Not just when you ate, when food goes all the way into the intestines from the stomach. These two hormones stimulate bile release and release of pancreatic juice. So far, Am I clear? More or less. Now, I'm kind of giving you sort of a preparation for the next unit. Look at this. What do you think stimulates gastrin? If it increases digestive activity in the stomach, what stimulates gastrin? Histamine and gastrin, what stimulates them? It's four-letter F word. Yes, it is food in the stomach, right? These guys, what stimulates them? Food, but in the intestine. Does that make sense? Because what they essentially do, these hormones, they regulate intestinal digestive activity. So far, we good? And there are two specific hormones that I wanted to mention. It's GLP and GIP. So GLP is glucagon-like peptide, GIP, gastric inhibitory peptide. Skipping the names, let's talk about the function. We call these guys insulinotropic hormones, which means they stimulate insulin release and have effects similar to insulin. Now, think about it from the regulatory perspective. You eat something, it ends up in your gut eventually. Are you with me? Whatever's in your gut gets digested, and the nutrients, such as glucose, amino acids, and triglycerides, they get in your bloodstream. So your blood glucose goes up, your blood amino acids go up. Am I clear? Remember, those two are the stimuli for insulin production. So it makes sense that your intestine produces a couple of hormones that give insulin an additional kick. You see what I'm saying? Like, hey, dude, food is here, digestion has started, pancreas, you better get going, beta cells, you better get going, producing some insulin because we need this uptake to happen right away. Make sense? These two are explored as potential treatments for diabetes. We good so far? Let's do liver. So, liver, so few, angiotensin. I'm not going to talk much about it. Remember we talked about aldosterone? How low blood pressure stimulates renin. Renin stimulates angiotensin. Angiotensin stimulates aldosterone. So angiotensin comes from liver. Okay? Are you with me so far? Somatomiddins. You have full right to say, what the hell? Somatomiddins, the hormones that you already know, it's insulin-like growth factors. Remember the axis for growth hormone? How growth hormone stimulates liver to release IGFs, and IGFs stimulate growth, cell proliferation, and protein synthesis. Indirect effects of growth hormone, remember that? So those are just mentioned. We already covered those. Just I'm kind of introducing a synonym. Somatomiddins is the same, just different term for insulin-like growth factors produced by liver in response to growth hormone. There we go. Okay? Got it? And really fun hormone. Thrombopoietin. So thrombo refers to platelets, like right thrombus. erythropoietin generation. I love the mechanism by which it works. Seriously, it's super elegant. So, right now, in every person in this room, I presume that nobody has any specific blood disorder. You have your platelets, okay? And the hormone is bound to the surface of the platelets. Am I clear? No? So molecules of hormone are attached to the surface of the plate. They're not free. They're not in the plasma. They're sitting on the cells. Okay? So as long as you have platelets, you, interestingly enough, have no free hormone. Does that make sense? It's not in the plasma. It cannot do anything. It is captured. Does that make sense? Imagine that for some reason, platelets are gone. The hormone is not. See that? Hormone is still there. But now this hormone is not captured by platelets. It's floating in the plasma. Does that make sense? Now it's suddenly a free hormone. It gets into the bone marrow, stimulates platelet production. Platelet levels go up, and guess what happens to this hormone? It gets bound to the platelets again. Am I clear? Make sense? So liver doesn't really have to produce much of it.
That only happens with this hormone?
Yeah, that's pretty unique for, yeah. This is what I like, this is such a cool mechanism. Okay? Got it? That's liver. We're not talking about hormones that regulate iron metabolism. It's super, super. Okay. Kidneys. Well, I'm going to put skin so I don't forget. So kidneys produce renin. Remember the aldosterone story? Low blood pressure. Renin, angiotensin, aldosterone. Okay? That's renin. It's kind of unique because it's the only hormone that is an enzyme at the same time. Okay? It's the enzyme that is a hormone. We good? We're going to talk about, it's called renin, angiotensin, aldosterone system. When we get to the renal part, we're going to talk more about this. And they produce erythropoietin, a Lance-Armstrong hormone, okay, which stimulates red blood cell production. It's a banned performance enhancement drug. Normally, when you are hypoxic or you lose blood or you lose iron, your red blood cells levels go down. Kidneys produce erythropoietin in response to that, and erythropoietin stimulates a number of red blood cells. It was used by cyclists to increase the aerobic performance. Oxygen transport in the blood. This is why I call it the Lance-Armstrong hormone. Okay? Yes? I believe so, yes. They increase erythropoietin levels. But I'm not sure if it's erythropoietin or, no, I think what they do actually, they isolate red blood cells because here's what happens. take blood away. Your blood levels drop, your red blood cells levels drop, right? So erythropoietin kicks in. It's a part of the response. Starts to accumulate red blood cells. By the time you get to the race, your red blood cells are normal, but you're injecting more erythrocytes, giving you some extra capacity to carry oxygen and to perform over others, okay? So it's not like injecting EPO directly, but you engage erythropoietin. I am a strong proponent of liquid doping. I think it should be legalized completely. It would be so much fun. Like a person running 100 meters in 6 seconds. I don't care what happens because it's all now competition between biochemists. Just make it legal. What's the point? What's the point of like people who come from the United States or Germany? They have better biochemists than people who come from, I don't know, Kenya or Ethiopia. They just don't have those resources. It's unfair. Let everybody just shoot anything they want. That's going to be fun. Skin, vitamin D. Okay. By the way, there's a one sport, strongman competition. You ever seen? They have clean tournaments and everything allowed tournaments. Everything allowed tournaments is so fun to watch. These people are insane. So vitamin D, part of the calcium homeostasis. Okay. We talked about it. Actually, vitamin D gets activated in the kidney by PTH. And this activated vitamin D is responsible for absorption of calcium from the food, from the intestine. Good? So far, makes sense? Okay, we are at our last. There is osteocalcium from the bones. I'm not going to even write it. Nobody really knows what stimulates it. It is known to be pro-insulin hormone. It stimulates insulin. I'm going to talk about a few of my favorite hormones. So hormones of adipose tissue, which are adiponectin and leptin. First, adiponectin. It used to be an enormous buzz around adiponectin when it was discovered. So adiponectin is produced by adipose tissue. It participates in the regulating energy intake. Although its role in regulating appetite is not completely clear. What adiponectin got its buzz for, we're going to call it AD, if you don't mind. Okay? So adiponectin is decreased in obesity, type 2 diabetes mellitus, hypertension, for instance. Okay? That makes sense? And it's been shown that in mice, for instance, if you take a diabetic model of a mouse and you give those mice adiponectin, adiponectin is very and strongly anti-inflammatory, cardioprotective, so it reduces the cardiovascular risks. It improves vasculature performance, so blood vessels feel better, and it helps mice to control sugar better, so it reduces insulin resistance. So it's like awesome. Okay? So the idea is that it is very strong anti-inflammatory hormone. Now, very interesting thing about adiponectin that when people study Now, think of it this way. So basically, you can say that inflammatory conditions, and believe me, type 2 diabetes mellitus, obesity, hypertension, are basically chronic inflammatory conditions. In these conditions, adiponectin is low, and administration of adiponectin improves, symptoms, whatever. When people started to look at autoimmune, chronic inflammatory conditions in mice, like humans, like rheumatoid arthritis or lupus, suddenly turns out that in those autoimmune inflammatory conditions, adiponectin is through the roof. It's super high, which kind of counterintuitive, right? If it's inflammation, it should be down. But here's the chronic autoimmune inflammation, and it's at astronomical levels. So the hypothesis is, there is an autoimmune condition which is accompanied by chronic, persistent, whatever you want to call it, inflammation. Adiponectin is produced as a part of a response to it. Does that make sense? But it doesn't work. It doesn't improve. So you can see concurrent inflammation and astronomical levels of adiponectin. Body tries to alleviate the inflammation but can't. Does that make sense? Like levels of TSH in dietary goiter. TSH is elevated, constantly stimulates thyroid gland, but it's useless because iodine is absent and it cannot produce thyroid hormone anyway. Okay? That makes sense? Costs like shit, I don't know. When I was injecting mice with adiponectin, they were like golden. After injection, each bus suddenly cost me like $100 or something. It's very expensive. It's really, like, pure adiponectin is really hard to make. And a tiny little, like, vial that was sufficient for 4 mice was like $400 or $500. It is insanely expensive. Now, leptin, much cheaper, it regulates satiety. So when you eat, after you eat, your adipose tissue produces leptin, which signals to hypothalamus that you're full. Make sense? And then you think, no, this pizza is just way too good. I'm going to have another slice. And then another slice. And then another slice. So along with ghrelin, those are 2 hormones which effects we can easily overcome, right? So, a couple of things. You have an illustration there in the PowerPoint of a kid who's like morbidly obese and then he's fine. And you have illustration of mice next to it. So these mice are leptin deficient mice. The phenotype is called OB, so both copies of the leptin gene are dysfunctional in those mice. They do not have internal control of eating. So you can put them on the regular mouse chow, like regular diet, no fancy. And they will eat so much that they will, I can tell you, I worked in obesity mouse model. So average mouse, lab mouse, weighs about 25 grams. I fed regular mice with really fatty diet, which tasted like, yes, I did try mouse diet. Tastes like cookie dough. Very, very good. So they got to, my record holder was about 60 grams. Dude was fat. OB mice, 60 grams is it's a boring Tuesday. They get to 70 and 80 grams. They're so fat, they can barely move. So like they feet, their limbs can barely touch the ground. So it's really hard for them to move around. Okay? They're like blobs. Okay? So leptin controls the appetite. And in that kid, there's no appetite. That's a genetic condition. But what's interesting, when people constantly overeat, Okay, so think of it this way. When you eat, so eating leads to elevated leptin. You should stop. But if you don't, and you keep on eating, leptin levels go up, and they stay up. And eventually your hypothalamus develops leptin resistance. So if you would take morbidly obese patients, I did that with my obese mice, and you take blood and measure leptin in the plasma, it's high. Because those patients develop leptin resistance. Does that make sense? So that concludes our endocrine story. Now is the last portion of today's class. And here we can